Okay, so we have a 2-year-old Asian boy who presents with bowel aches and poor weight gain. He was breastfed for the first year of life and now he is on cow's milk diet. Mother says that he is not as active as other boys of his age with poor food intake. On examination, he is pale with a prominent forehead and a marked bow leg deformity. He also has swollen wrists. His height is on the 25th centile and his weight is on the second. No restriction of movement or bone pain is noted. On the right, we have the blood test results. So I'll give you 5 seconds to pause the video and come up with your diagnosis. Okay, so the correct answer is rickets. So let's work this out together, shall we? So looking at the blood test results, we see that his hemoglobin is low. Uh, his MCV, mean cell volume, is also low, and mean corpuscular hemoglobin is low. Looking at the ferritin, is low as well. This confirms the diagnosis of iron deficiency anemia. Now, the other uh, abnormal blood test results is the significantly raised alkaline phosphatase or ALP, and even the calcium is borderline. So if you look down here, so going through the option, A, osteoporosis. Is it really? Because our patient is really young and osteoporosis is a disease of the aging. So we can rule that one out. Osteosarcoma. Osteosarcoma characteristically presents with bone pain, restricted range of movements, and the bone pain is actually really bad at night. There's also palpable masses, but then we are told that the outpatient does not have any restricted range of movements or bone pain. So we can rule that one out as well. Celiac disease. Now, this is an interesting one. Yes, celiac disease can give rise to iron deficiency anemia, but then do we have enough information to diagnose our patient with celiac disease, such as abdominal pain or bloating or antibody testing, such as the uh, anti-tissue transglutaminase antibodies, or even family history? We haven't been told any of those about any of those, so we can rule that one out. Chronic kidney disease, you could say that, but then this has to be severe for rickets to happen, so we can rule that one out as well. Because remember, in chronic kidney disease, the vitamin D metabolism is also affected, but then again, it has to be severe enough to cause that. And chronic kidney disease is really a disease of the aging again. So, let's learn more about rickets. So the clinical features include swollen wrist and ankle, which was the case in our patient. He presented with swollen wrists. Frontal bossing, we'll talk a bit more about that later, and prominent costochondral junction or uh, rickety rosary. I'll show you a picture of this as well. Then we have the bowel aches, and which was the case in our patient. We have muscle weakness, probably due to low calcium, because remember calcium is needed for muscle contraction to happen. Tetany, again, because of low calcium. Hypocalcemic fits and rarely cardiomyopathy, both of which are again due to low calcium levels. Now, pathology, it is more common in the dark-skinned children because they obviously need greater sun exposure to synthesize vitamin D. Another interesting risk factor is that uh, for religious reasons. So people who cover their body are more prone to have low vitamin D, or in those who are generally less exposed to sunlight. Another risk factor is the prolonged breastfeeding, because remember, breast milk has low vitamin D as well as cow milk. But then infant formula, they're rich in vitamin D to address the problem from the beginning. And severe renal and liver disease. Now, how do we diagnose it? So vitamin D are low to confirm the cause. We obviously want to rule out celiac disease, because celiac disease can present in similar way with iron deficiency anemia and low vitamin D, by doing some antibody testing. And again, ALP is markedly raised, which is classic of rickets. Okay, so remember that ALP is always raised. Management, the prognosis is generally good. We give them vitamin D supplements and iron supplements if there's any evidence of iron deficiency anemia. Then we refer them to the dietitians. Now, so what is rickety rosari? So if you look down here, there are some raised tenderness or nodules, if you like, here, here, and here. The one on the right is more prominent, so you can see it for yourselves. And if you notice carefully, these tend to happen at the costochondral junctions, which is characteristic of rotary rosari. Then we have the bowel legs. If you look here, both of these patients have their legs kind of bowed. It's not straight. And then we have the prominent frontal bossing. If you look down here, their forehead is kind of protruding forward. I've included this table here for you just to have some differential diagnosis for yourself. If you learn this, trust me, you'll be really confident when it comes to interpreting calcium, ALP, PTH results. So please do go ahead and take a screenshot of this table and then try to learn it. It's really easy once you go through it for a few times. For instance, osteoporosis, you know that it's a chronic condition, and you tend to find calcium, phosphate, ALP, and normal PTH. And always remember that it's more common in women, especially in those who are postmenopausal. So I hope that was useful.